أشكر دكتور مجدي دهشان والدكتور محمد البرعي على دعوتنا للمؤتمر الأزهر. وزي ما انتم عارفين أنا أزهري أصلا رغم إني متخرج من جامعة القاهرة. تاريخ جامعة الأزهر عريق، وزي ما قال أستاذ الدكتور على حكاية بداية جامعة الأزهر في كلية الطب سنة 63، فأنا حضرت جزء من التاريخ بتاع بداية الجامعات العلمية في الأزهر. دلوقتي نقدم الأستاذ الدكتور أسامة عبادة هيكلمنا على سمول مولكيولز ان ألسراتيف كولايتس. أستاذ أسامة عبادة أستاذ في جامعة اسكندرية ومن أكثر الناس اللي اشتغلوا في مجال الاي بي دي، وكلنا بنلجأ له لما يكون عندنا مشكلة مع عيان ونحب ناخد رأيه دايما. تفضل دكتور أسامة.
ألف شكر على الكاين برزنتيشن بالدكتور مازن، وبشكر الدكتور مجدي والدكتور محمد البرعي for inviting me for this 10 minutes talk. I'll try to be stick to the time, but I'll try to be updated in what is in the last year in the treatment of use of small molecules ulcerative colitis. First of all, this is the line of the old drugs that has been usually the biologics in the field of the IBD. And as you started by 2003, as you can see here, the infliximab was introduced for Crohn's disease. And with time, we moved to adalimumab, vidozulumab, and tofacitinib was the first molecule that was introduced in 2018. And after that, ozanimod has been approved for ulcerative colitis last year. Phlegotinib is approved in Europe for Crohn's disease. I won't talk about it because Dr. Khaled will talk about Crohn's disease. And then the last was the approved maybe a few weeks ago, the upadacitinib for ulcerative colitis. So the currently approved therapy is traditional corticosteroids and others, as you can see that, and biologics, which include the TNF inhibitors, the IL-12-23 inhibitors, secukinumab, and now and integrin antagonist vidozulumab, and then the small molecules, which include the JAK inhibitors, tofacitinib, upadacitinib, and S1P inhibitors, sphingosine 1P inhibitor, ozanimod. So we'll try to talk about those. The JAK inhibitor assay. JAK inhibitors has multi-activity in the hematopoietic system, inflammatory system, as well as many areas of the body, but it usually occurs through its action through 4 receptors: JAK1, JAK2, JAK3, as well as tyrosine kinase 2. And the selectivity that what we have is tofacitinib, OPA, and phlegotinib. OPA as well as phlegotinib are JAK1 selective, while the tofacitinib is pan JAK1, JAK3, tyrosine kinase, and has been the first was approved to 2018. This is due to the OCTAVE study. This has been published 2017 in New England, as you can see that. And this is the first publication for the use of the tofacitinib in ulcerative colitis, and after that has been approved for the use of treatment in ulcerative colitis. As you can see, the maintenance here is up to 40% up to 1 year mucosal healing in those patients. And also there was a recent publication last year, 2021, about the use of what they call extended induction for tofacitinib, which short of rescue for the tofa, because you can have, if the patient have delayed response, you can extend the double dose for another 8 weeks, and you can save more than 20%, and you reach 70% instead of 50%. Tofacitinib, as all other drugs, oral drugs, have very rapid onset of action as early as 3 days. That you can have the start of the action, and you start production in the stool frequency as well as the bleeding by 2 to 3 days only of action. And if compare the oral with the rest, and this is the network meta-analysis, we can see that the OCTAVE study here, and this is the tofacitinib, and it is just second to the ustekinumab in clinical response as well as in clinical remission by 1 year. Also, the relative efficacy for patient biologic naive, tofacitinib is ranked after infliximab and Vido in ulcerative colitis naive, so it is even better than ustekinumab for the bio-naive. For the bio-failure, this is the first drug to be used for the anti-TNF exposure. Tofacitinib is better than ustekinumab in bio-failure. And this is the AGA update after this updated network meta-analysis, and they said that the bio-naive infliximab is the best drug, while the prior anti-TNF, ustekinumab, and tofacitinib are superior to Vido and adalimumab, while the safety, the best is the Vido, and second is ustekinumab. If you are taking the tofacitinib versus ustekinumab in failure, the advantage for tofa is that it's faster response, oral, rapid absorption, and there is no immunogenicity, while the need to have a sort of regular follow-up, not well-defined, especially in risk profile, and it is not recommended during pregnancy or breastfeeding yet. While the ustekinumab is excellent safety, while it is slow, and it has long half-life and, of course, potential antibody development that the small molecule don't have it. If you have positioning of the small molecule, you will find that if you have the IBD or ulcerative colitis with rheumatoid arthritis, yes, you can use TNF or TOFA because TOFA is already indicated for rheumatoid arthritis. And as of course, for patient or anti-TNF failure, the first is TOFA, followed by ustekinumab and Vido, as we said. Also, tofacitinib has been used in acute severe ulcerative colitis, and this was the first report for patients only, and after that, another larger study by Higgins and et al. In Michigan, and they said they have a biologic experience in patients, 40 patients, and they have a rescue patient and used, but the level of the drug was TID, 10 milligram TID, which are a high dose, but it can save about 80% of patient infliximab for here could save about 80% from colectomy. So it could be used either in patient already TNF failure or in patients already not responding to infliximab, you can add TOFA. But of course, the safety it usually does response, and the problem is the herpes zoster. Other is not that high. No dose relationship with malignancy as well as non-melanoma skin cancer, but the herpes zoster is the indication, and this is the potential management that you can abroad you can have a sort of herpes zoster vaccination. But also you need to have this. Some patients have increased creatine kinase. Some patients have a sort of increased transaminases, so that you need to regularly check the AST/ALT. For cytopenia, you need to check for cytopenia. A small dose, but a small percentage, but also lipid profile can increase in some patients, so you need to check it every 3 to 6 months. The second is upadacitinib. Upadacitinib now has been approved a month ago, that due to new achieved study, and it has a very excellent response, especially in ulcerative colitis, and soon, maybe by the end of this year, it will be approved for Crohn's disease. And you can see by the end of 8 weeks, you can have around 50% histologic improvement, which is a significant number of response. And this is the UAchieve study, and also it has been clinical remission also has been noticed in such patients. This is published this year, and you can see that this response we have seen in UAchieve, and this has been as early as 2 weeks with the drop of CRP and fecal calprotectin. Clinical response, as you can see, the UAchieve, you can reach about 70% by 8 weeks. And also you achieve about 75% response. So it is a very high response as early as 8 weeks, and you accomplish also starting this. You can see by week 2 you start to notice the response and maintain this response. And this response also for OPA 45, you can notice how the difference between endoscopic improvement between placebo and between the OPA dosage. Also, by 52 weeks, about 50% will have mucosal healing and clinical remission, as well as endoscopic mucosal healing by about 50% or something by the end of 1 year. So, and that's why upadacitinib has been approved for ulcerative colitis just last month by the dose of 45 milligrams in those patients with no side effects. The second group is VEGF inhibitor, is a S1P receptor modulator, and this is the ozanimod, has been approved for ulcerative colitis, and the way of action is to block the passage of the active lymphocytes in the lymph nodes. So they prevent their aggression, and what is approved is ozanimod, and etrasimod has been in phase 3 now, so and expected to be approved soon. So ozanimod has been approved for ulcerative colitis. This is the first study, and this is the second study. This is the True North study that has been clinical response by 50% by week 10, and 12% or 13% by the end of the year. You can find about 30% mucosal healing by the end of 1 year. The clinical response, as we said, starts by week 2, the same as other oral. By week 2, you have very good response. And this comparative efficacy and safety of ozanimod versus adalimumab and vizirumab in patients with moderate to active severe colitis. And you can see that ozanimod is better than or comparable to Vido, and better than actually adalimumab. And the results of this is that ozanimod better than adalimumab in ulcerative colitis, and or comparable to Vido if you put safety in consideration. Etrasimod has been tried, as we said, in ulcerative colitis, expected to be approved soon, and this is the results. Comparable but less than better than ozanimod, but need to be approved. The concerns of us S1P receptor modulator is infection, lymphopenia, AV conduction delays. This is has been not seen in the JAK, and macular edema. This is the summary. That severe disease, you can use JAK, of course. Ozanimod not that severe. Safety, ozanimod is better. JAK less. TNF failure, the best is JAK. Ozanimod, yes, you can use it. There's serious recent reports. Onset of action, as you said, very 2-3 days JAK, 2 weeks in ozanimod. Extra administration, JAK, you can use it. Ozanimod, you don't know yet. So by safety, now this is the pyramid of safety. Steroids is the worst. Combination TNF combo is worse, is second. TNF and TOFA are next. Ozanimod and upadacitinib better than TOFA, and the best safety yet is Vido and ustekinumab. In conclusion, early diagnosis, early management of Crohn's disease Crohn's and ulcerative are critical, and you need to minimize the complication, ensuring positive outcome. And the personalized IBD care now is the future of our management. Thank you very much.
شكرا استاذ دكتور اسامه. هنخلي الاسئله في الاخر. اسف انا نسيت اقدم رؤساء الجلسه. الاستاذ الدكتور شريف عبد الفتاح غني عن التعريف، الاستاذ الدكتور ادريس سعيد from عين شمس يونيفرستي، دكتور محمد ابو شادي من الازهر يونيفرستي. ناتي استاذ الدكتور شريف عبد الفتاح.
May I present please Professor Khalid